Hello, let's do the next stations from the critical care for MRCS Part B. So the next station is epidural about epidural anesthesia. Okay, the scenario is patient had epidural anesthesia is at T3 and T4, normal T4 and T6. Lobectomy using thoracic epidural. Okay, now has hypotension, bradycardia, desaturation, upper limb paresthesia, and oliguria. So, what is the differential in this scenario? So, the differential can be first high epidural block, distributive shock secondary to epidural, paralysis of intercostal muscles, paralysis of diaphragm, hemothorax or pneumothorax, post-operative hypovolemic shock. Then why patient have bradycardia? So high epidural block lead to blocking of the cardio accelerator fibers, sympathetic fibers from T1 through T5, which lead to unopposed parasympathetic action of the vagus nerve. Okay, so that's why patient have bradycardia from the unopposed action of vagus nerve. Now what will be the management plan? So management plan will be according to care of critically ill surgical patient. Okay, then we will call the operating consultant and anesthesia consultant, sit the patient upright, give 100% of oxygen, stop any injection in the epidural catheter, rule out any concomitant hypovolemic shock, epinephrine, phenylephrine, meta aminol, which are inotropic agents, should be given, and atropine, which is chronotropic agent, should be started. Okay, then factors affecting epidural efficiency. The factors which affect epidural efficiency can be level of injection, dosage, type of medication, vasoconstrictors, postures, and age and uh, age, height, and weight. Okay, so these are the factors which affect the efficiency of epidural anesthesia. Okay, and then what are medications that are used in epidural anesthesia? So they can be local anesthesia, local anesthetics like lidocaine and bupivacaine. Okay, bupivacaine and lidocaine with an opioid like fentanyl. Okay, so these are the local medication used in epidural anesthesia. Why epidural anesthesia in this case? Is it is the longer surgery, so in order to ensure the early mobilization of the patient after longer surgery, it is given. Then the second reason is post-operative analgesia, pain relief for longer periods. Then improve outcomes. Okay, so by decreasing the neurohormonal stress hormone and improve cuff reflex and improves recovery. Okay, so these are the uh, reason why the epidural is given in this case. How to test the level of the block? Using temperature sensation eye specs. Okay, so we will test the level of the block by the temperature sensation by using eye specs. What else beside eye specs? So ethyl chloride spray can be used also to test the level of the block. Why we use the temperature sensation? Because of the arrangement of the fibers, the motor fibers are the last to be affected. Okay, why temperature and not pinprick sensation? So we are not using the pinprick sensation or pinprick test because it is painful, bleeding is possible, and there is possibility of infection. Then how to differentiate epidural block from the hypovolemic shock. So in the epidural block, the peripheries will be warm and pink and there will be bradycardia, while in the hypovolemic shock the peripheries will be cold and clammy and there will be tachycardia. Then the systemic effects of epidural analgesia. So, systemic effects of epidural analgesia includes hypotension due to block of the sympathetic outflow causing peripheral vasodilation. Then reduced cardiac output due to reduction in the venous return. Then attenuation of the surgical stress response, reduction of functional residual capacity, reduction of post-operative DVT due to number of causes including the concomitant use of the IV fluids used to support the arterial pressure. Okay, so these are the systemic effects of epidural analgesia. Then who would you involve beside anesthetist? So we will involve the operating consultant in this case. Then what sign and symptoms would tell you patient is getting worse? So if there is decreasing blood pressure, decreasing heart rate, decreased oxygen saturation, paresthesia and oliguria, then these signs will tell us that patient is getting worse. Okay, so this is about epidural anesthesia, which is a small station. Then about the nutrition and surgical feeding option. The scenario is a critically burn ill patient is in ITU and requires nutrition. In this station, you will be asked the physiology of nutrition and its clinical application. Then the scenario number 2 is lady with Crohn's went for ileocecal resection. On post-op day 4, there was an anastomotic leak. Defunctioning ileostomy was done. Okay. Then the question is describe what you see in radiographs. Okay, describe what you see in radiographs. Okay, so in this radiograph, this one, okay, this is an AP chest radiograph of an adult, male or female. The patient gender would be mentioned. Then the radiograph chest X-ray or the radiograph view is adequate, and the NG tube cannot be seen bisecting the carina, and it is not remaining in the midline above the level of the diaphragm. The tip of the nasogastric tube is also not visible below the diaphragm. I can confirm that this tube is not in a safe position to commence feeding. Okay, so you can see the tip is not the tip is not visible below the diaphragm, so it is not safe. While in this radiograph you can see the tip is crossing the or it is visible below the diaphragm, so it is safe for safe position to commence feeding. Okay, so in order to commence feeding, the NG tube should bisect the carina, okay, which is the point at which the trachea bifurcates into right and left bronchus. It must be remain in the midline to the level of the diaphragm, okay, and the tip of the nasogastric tube must be visible below the diaphragm, okay, and is at least 10 centimeter beyond the gastroesophageal junction. Okay, so that's will be the criteria to be for the NG tube to be safe for commencing feeding. How to confirm correctly place NG tube? So according to NICE guidelines, there are two methods. Measure the pH of aspirate using pH indicator strips or paper. And the second method to confirm the NG tube is correctly placed or not is the radiography chest X-ray. Okay, then the other question is methods which should not be used for confirming NG tube position. It include auscultation of air insufflated through the feeding tube, whoosh test. So whoosh test cannot be done to confirm the NG tube position. Then testing the acidity or alkalinity through the feeding through the aspirate using blue litmus paper. So it is not the confirmatory method. Then the third method which should not be used is interpreting the absence of respiratory distress as an indicator of the correct position. Then monitoring bubbling at the end of the tube, it is not a good method, it should not be used. And observing the appearance of NG tube aspirate. So these methods should not be used to confirm the NG tube position. Then this question, if the pH is 5.5 in aspirate, what will be your action? So as the pH of the stomach is between 1.5 to 2, so as the pH is raised, it is not in the stomach, so just pull the tube out. Then the other question is, what does abdominal X-ray show? So this is the abdominal X-rays. Okay, so you can see this is the small bowel. Okay, in this diagram, in this X-ray also there is small bowel, and it shows the stack of coins appearance, and the stack of coins appearance is visible, or it is confirmatory for the small bowel obstruction. So the abdominal X-ray show the small bowel dilatation, stack of coins appearance. What may be the cause in this patient? Okay, so the cause may be the stricture due to Crohn's. As the patient has Crohn's disease, so the Crohn's can lead to stricturing. Then the feeding option, methods of feeding. So it can be parenteral, which include total parenteral nutrition, and peripheral parenteral nutrition. Okay. Then the enteral feeding, it can be NG tube, nasojejunal tube, and surgical jejunostomy. Okay, so these are the methods of feeding. Then types of enteral or non-parenteral feeding include oral feeding, nasogastric, nasoduodenal, nasojejunal. Okay, nasojejunal. Then the percutaneous. Then the percutaneous endoscopic gastrostomy, which is also called PEG, and jejunostomy. So these are the enteral feeding methods. Now, why was nasojejunal is preferred over nasogastric? Advantages and disadvantages of nasojejunal tube. Advantage is that it bypasses the stomach, so there is less liability to pneumonia, avoids gastric phase of stimulation. Okay, doesn't stimulate the pancreatic secretion, and feed delivered directly to the intestine, thus maintaining the mucosal integrity. Okay, then the disadvantage is need endoscopic guidance for placement and smaller in diameter, so that's why it is more prone to kinking. So these are the disadvantage of the nasojejunal tube. Then the complications of enteral feeding, it can be tube related or feed related. So the tube related, kinking can occur, misplacement can occur, injury can occur in the tract through which the NG tube pass, or nasojejunal or nasogastric tube pass. Okay, so the migration can occur, blockage can occur, infection and aspiration pneumonia. Then the feed related complications of enteral feeding include diarrhea, nausea, vomiting, aspiration, refeeding syndrome, fluid and electrolyte imbalance, and deranged liver functions. Okay, so these are the feed related complication of enteral feeding. Then the complications of the parenteral feeding. Okay, so we will discuss it later in this session. Okay, then this question, what is refeeding syndrome and cause behind it and why it is fatal. So it is a metabolic disturbance which occur on a feeding person following a period of starvation. The metabolic consequences include hypophosphatemia, hypokalemia, hypomagnesemia, abnormal fluid balance. Okay, so it is a basically metabolic disturbance which occur when person start feeding following a period of starvation. Okay, then the patient which are at high risk for refeeding syndrome include the two criteria. Okay, this is first criteria. Okay, this one is first criteria. If one or more of the following is present, then the patient are at high risk for refeeding syndrome. If BMI is less than 16 kilogram per meter square, unintentional weight loss more than 15% over 3 to 6 months, little nutritional intake more than 10 days, hypokalemia, hypophosphatemia or hypomagnesemia prior to feeding. Okay, then the second criteria, if two or more of the following is present, then the patient will be at high risk for refeeding syndrome. BMI less than 18.5 kilogram per meter square, unintentional weight loss more than 10% over 3 to 6 months, little nutritional intake for more than 5 days, and history of alcohol abuse, drug therapy including insulin, chemotherapy, diuretic and antacids. So these are the criteria for the patient at high risk for refeeding syndrome. Then how to prevent refeeding syndrome? Then there are three methods, okay, which must be followed to prevent the refeeding syndrome. The first is start at up to 10 kilocalories per kg per day, increasing to full needs over 4 to 7 days. Then the second method is start immediately before and during feeding. What should we start before and during feeding? Oral thiamine 200 to 300 mg per day, vitamin B co strong 1 TDS and supplements. Then the third method is give potassium 2 to 4 millimole per kg per day, phosphate 0.3 to 0.6 millimole per kg per day, and magnesium 0.2 to 0.4 millimole per kg per day. Okay. Then signs of malnutrition. Patient identified as being malnourished. So signs of malnutrition. Okay, so the patient identified as being malnourished if he have BMI more less than 18.5 kg per meter square. Then unintentional weight loss. Okay, unintentional weight loss of more than 10% over 3 to 6 or 12 months. Okay, then the BMI less than 20 kg per meter square and unintentional weight loss of more than 5% over 3 to 6 months. Okay, so these are the malnourished patient. Okay, now at risk of malnutrition, okay, which persons are people will be at risk of malnutrition. So the first is eat nothing or little for more than 5 days, who are like to eat little for a further 5 days. Then poor absorptive capacity, high nutrition losses, high metabolism. Okay. Then the next question is indications of TPN. Okay, so it can be general critical illness and gut problems. So general critical illness involves severe malnutrition, more than 10% of weight loss, multiple trauma, sepsis with multiple organ failure, and severe burns. Then the gut problems include short bowel syndrome, intracutaneous fistula, bowel obstruction, IBD, inflammatory bowel disease, and radiation enteritis. Then roots of TPN, total parenteral nutrition administration, is central line or BICC. Then types of electrolytes in TPN include the sodium chloride, calcium chloride, potassium chloride, and magnesium chloride. What are the main contents of the enteral or parenteral feeding? So the components includes water, carbohydrate 50%, lipids 30%, proteins, vitamins, nitrogen, and trace elements. So these are the main contents of the enteral or parenteral feeding. How it is given? Okay, in a central line, because of high osmolarity, must be more less than 900 milliosmol per liter. Other than glucose, what other TPN constituents provide the energy? Okay, so it can be fat, which provide 50% of energy. Patient with mandibular fracture. Okay, so the patient with mandibular fracture, what indication for fixation? What will be the indication? Avoid pain in mastication and cosmetic reason. So the complications of the TPN, total parenteral nutrition, it is line related or feed related. Okay, so the line related include infection like sepsis and thrombophlebitis, thrombosis, pneumothorax. Feed related include fluid overload or overfeeding, electrolyte imbalance like hyperchloremic metabolic acidosis, hyperlipidemia, hyperammonemia. Okay, essential fatty acid deficiency, hypo and hyperglycemia, ventilatory problems due to excess production of carbon dioxide if too much glucose is used in the mixture. Okay, in the ventilated critically ill patient, the amount of glucose given in 24 hours may have to be restricted to 5 gram per kg. The most potent risk is that of a refeeding syndrome, particularly in the chronically malnourished patient. Then the last one is gut atrophy due to the absence of tropic signals released in response to luminal nutrients during regular feeding, which will be lead to bacterial translocation. Okay, so gut atrophy is also one of the complication of TPN. Then the next question is nutrition. How we will monitor the nutrition? Nutrition monitoring will be according to NICE guidelines. Okay, so the weight should be monitored daily if fluid balance concerns, otherwise weekly, reducing to monthly. BMI to start of feeding, at start of feeding, and then monthly. Then, if weight cannot be obtained, monthly mid circumference or tricep skin fold thickness. Daily electrolytes until level stable, then once or twice a week. Weekly glucose, phosphate, magnesium, LFTs, calcium, albumin, full blood count, MCV level if stable, 2 to 4 weekly zinc, folate, B12 and copper levels if stable. Okay, so these are the, then the next is 3 to 6 monthly iron and ferritin levels, manganese if no home parental regime, 6 monthly vitamin D, and bone densitometry initially on starting home parental nutrition, then every 2 years. Okay, so these are the nutrition monitoring in the TPN. Then from which sources may the energy requirements be satisfied? How much energy does each of these provide? So the fats provide 9.3 kilocalories per gram of energy. Glucose provides 4.1 kilocalories per gram of energy, and protein also provides 4.1 kilocalories per gram of energy. Okay, so the fats provide most of it, 9.3 kilocalories per gram of energy. What are the disadvantages of using glucose as the main source, energy source? So it can be glucose intolerance. Okay, glucose intolerance. As part of the stress response, critically unwell patients are often in a state of hyperglycemia and glucose intolerance. Therefore, if glucose is the only source of energy, patient will not receive their required daily amount due to poor utilization of their energy source. So glucose intolerance. Then the fatty liver, the excess glucose occur as a consequences of the above is converted to lipid in the liver, leading to fatty chain. This may derange the liver function test. Then the respiratory failure, the extra carbon dioxide release upon oxidation of the glucose may lead to respiratory failure and increased ventilatory requirements. Then the relying solely on the glucose may lead to deficiency of the essential fatty acid. Therefore, 50% of the total energy required must be provided by fats. So we already discussed this question, complications of the TPN and complication of enteral feeding. Then the next station is preoperative aortic stenosis. Okay, the scenario is there is plan of elective transurethral resection of bladder tumor. Patient has history of aortic stenosis. Then the first question is pathophysiology of the aortic stenosis. What are the problems you might face? We already discussed it in the pathology lecture of the station of the aortic stenosis, that in the aortic stenosis there is lipid accumulation. Okay, then there is fibrosis. Okay, fibrosis, and then there is stenosis. So lipid accumulation leads to inflammation, then fibrosis, and then stenosis. And the fibrosis, the aortic stenosis cause the fixed cardiac output. Okay, fixed cardiac output and fixed stroke volume. Okay, define aortic sclerosis. So the calcification and thickening of the aortic valve leaflets in the absence of obstruction of ventricular flow. How to calculate the coronary perfusion pressure? So coronary perfusion pressure will be equal to systemic diastolic arterial pressure minus left ventricular and diastolic pressure. Okay, in aortic stenosis, coronary perfusion pressure decrease because left ventricular and diastolic pressure will increase. Then the clinical picture of the aortic stenosis, the symptoms can be syncope, anginal pain, dyspnea, paroxysmal nocturnal dyspnea, orthopnea, and sudden death. Signs of the aortic stenosis include pulses, alternating strong and weak beats, narrow pulse pressure, paradoxical splitting of S2, and ejection systolic murmur. Okay, so these are the signs which are present in the aortic stenosis. Once the patient is asymptomatic, it is severe aortic stenosis, and this is and for surgery it is severe aortic stenosis, so surgery cannot be performed in this case. Examiner will give you ECG identifier. Okay, so in this ECG there is positive depletion of the lead 1, okay, and lead AVL, while there is negative depletion of lead 2 and AVF. So it shows the left axis deviation, which is due to left ventricular hypertrophy. Okay, how to calculate heart rate based on the ECG? So in order to calculate the heart rate, first we will look if the rhythm is the regular or irregular. If there is regular rhythm, then we have to use this formula: 300 divided by number of large square between two RR intervals. But if the rhythm is irregular, then we will count the number of QRS complexes in large number of QRS complexes in 30 large square and then multiply by 10. Okay, so this is how we can calculate the heart rate. What are the complications of aortic stenosis? It include left ventricular hypertrophy, hypertension, congestive heart failure, ventricular tachycardia and fibrillation, angina, and intraoperative sudden death. What investigation to do for the aortic stenosis? It is 2D echocardiography, which is transesophageal echo, okay, and then chest x-rays. Okay, so these are the two investigation. What to do if patient is going for surgery? Then we would inform the consultant and anesthesiologist and ask them about advice before cancelling. Then cancel the operation if the patient is symptomatic. Call the operating theater to cancel listing, explain to the patient and discuss in multidisciplinary team. Okay, so the next question is treatment of severe aortic stenosis. It can be surgery, which include valvuloplasty and valve replacement. Then cause of sudden death in aortic stenosis, it can be to acute MI and rupture aortic dissection. Okay, if the patient underwent surgery for valvuloplasty or valve replacement first, when you can do another surgery like bladder surgery, so after 6 months. Okay, then the next question, if the patient has emergency surgery, perforated viscous and has severe aortic stenosis, what are you going to do? So first we have to do ballooning for the valve, then we can go for the life-saving surgery after 12 to 24 hours. Okay, then the next question, what thiazides complication might result in postponing the surgery? So it can be hypokalemia or hyponatremia. If this patient had a bladder cancer, okay, will you proceed to bladder surgery or valve surgery first? Okay, so this depends on the severity of the aortic stenosis. Okay, so if there is severe aortic stenosis, then we cannot go for surgery. Okay, so these are the diameter which shows aortic surface area, which shows the severity. Normal is 3 centimeters square or greater. Then the mild aortic stenosis 1.5 centimeters square to 3 centimeters square. Okay, then the moderate aortic stenosis is 1 to 1.5 centimeters square then the severe is 1 centimeter square or less. Okay, if the operation was cancelled, what are you worried about? So we will worried about spread of cancer. Okay, if you proceed to surgery, then what we will do, we will give prophylaxis, preoperative antibiotic prophylaxis against infective endocarditis according to NICE guidelines. Okay, so this is the aortic stenosis. In the next lecture, we will discuss the next station starting from the atrial fibrillation.